I'm Dr. Poplawski, and I'm a bariatric surgeon, and that's a general surgeon who has decided to specialize in this field. And I've been doing this about 14 years and more than 3,000 cases now. Bariatric surgery is surgery that helps people lose weight. Baris is a Greek root, means weight. Barristers, the lawyers with the scales, barometric pressure, weight of the air. We treat a disease here called morbid obesity, which sounds kind of bad. I think the first time you heard that you probably wanted to slap somebody, but it's really just two medical words. Obese is a condition of too much body fat. Can live with that. Morbid doesn't mean bad or ghastly or unsightly. In the medical world, morbid means now in a diseased state. So a condition of too much body fat that has progressed to a level where it's starting to cause other diseases like diabetes and hypertension and sleep apnea and destroyed joints and reflux and asthma and premature heart disease and polycystic ovaries and bladder dysfunction and all of these illnesses that are the direct result of too much body fat for too long. Things that are threatening your life, threatening your health, damaging your health, shortening your life, and taking away a lot of fun. Now, the first line of treatment for morbid obesity is to eat less and exercise more. Anybody tried that yet? Yeah, right. That's plan A through Z. And when it doesn't work, then the next thing is to work with a real doctor. See, is there some medical reason why this is not working for me? Is my thyroid okay? Is there anything else going on? Do you have anything here in your bag of tricks to help me control this life-threatening illness without an operation? Because nobody really wants an operation unless there is no choice, So diet pills, nutritional therapy, exercise counseling, everything, short of an operation should be given a reasonable try until it seems unreasonable to keep trying. And that's when it's time to talk to us, okay? So we're not the first line and we're not the second line. And what that means then is what I get to take care of here are basically the failures. Oh no, another hard word. Of the medical management of obesity, okay? So those are the people that get surgery, is the ones that nothing else works for, okay? And for me, the really interesting question is not, does this patient qualify for bariatric surgery? That's pretty easy. I get out the chart, I look up your height and your weight, and either you're above the line or you're below the line. But the really interesting question and the really important question, I believe, is why? How in the world did this happen? How come these normal, intelligent, educated, hardworking people can do whatever they want in life except control their weight, even though their life is in mortal danger? Hi. If they want to. Yeah. Come on in. Listen. The interesting question is why? Why did I do this to myself? Why did this happen? What's really going on here? Why do I need those guys? And, part of it is genetic, and part of it is, how you were born and raised, but a lot of it is our environment and our behavior. How we manage our stress, how we soothe and comfort ourselves when we need to be soothed and comforted. And some people choose alcohol, some people choose nicotine, some people choose food, and that's some of the things that we can change. So the parts of our behavior that cause this, that we can change, we need to start thinking about how to manage that better and how to change those things. Okay, so it's a multifactorial thing that caused this life-threatening problem of morbid obesity. And there are some things that we can change, some things we can't change. But what I've learned over the past 14 years of doing this is that there are important things going on about food, in our patients' lives that have to be made better. Okay, how you manage your stress, how you soothe and comfort yourself, how you manage your boredom, how do you respond to anxiety. Food works. That's the problem. It works really good. It makes us feel less bad when we're feeling bad. It makes us feel less anxious when we're anxious. And a big part of this is being able to understand that and to start to change that, okay? And to be able to almost proactively replace the food with another way. You know, so that when these feelings come back, you know, you grab your coat and you're out for a fast walk, or, you know, you're digging in the garden, you're singing in the church choir, you go to a karate class or something where you can, you know, recover, rest, unstress. Okay? How you shop, how you cook, you know, your food choices, the foods you have available in the house, how you build time into your busy life to go for a walk, to get some exercise. You know, even with perfect bariatric surgery, these things have to change. You know, I like to use the analogy of that 55-year-old vice president of the company, works about 100 hours a week, no time for exercise, super stressful job, super stressful family life, 50 pounds overweight, pack and a half a day nobody knows about. Now all of a sudden he's got chest pains. You know, so he goes and sees his doctor. Doctor gets him over to the cardiologist. The cardiologist pops him right in the hospital, does a cath on him the next morning, serious blockages, ready to have the big one, the widowmaker. So they get him over to the world's greatest heart surgeon, and he takes some veins out of the leg and bypasses all those blockages, and chest pain's gone, heart's working better, you know. But if he doesn't change those behaviors that cause that, you know, in 3 to 5 years he's in big trouble again. And bariatric surgery is a lot like that, okay? You know, the operation will help you lose weight, but at the same time, you've got to start to work on the things that cause this. Okay, and those are the patients that really do well long term, you know, to, you know, really close this chapter in their life, to get control of this life-threatening illness, to be able to say, yeah, that's what I used to do, and I don't do that anymore. You know, being able to talk to a psychologist, a therapist, a counselor, you know, about, you know, why is this so hard for me? You know, why do I need those guys? You know, that's probably a good idea. Blue Cross makes everybody go. Okay, if you got a Blue Cross plan, you're going to have to see a psychologist at least once. Okay, and he's going to ask you all these nosy questions, because that's what they do. And then when they get done and they, you know, they say, do you have any questions for me? What I want you to do is say, yeah, why am I here? You know, why do I need those guys? This is ridiculous. You know, what's really going on here? And to start that conversation and to start make yourself more sophisticated at understanding these things. You know, and to change the things that we can change. Okay? I think that'll be about as important as what I do in the operating room for you when it comes to long term. You know, after surgery, if you find yourself starting to do things to defeat the operation, you know, these old behaviors are coming back. You get in with Sigmund Freud again and find out, you know, what's really going on now. If you find that your spouse, your partner, your husband is starting to do things to defeat the operation, you get in together and find out, what are you afraid of now? I tell all the married women that during the first year, you're going to have to tell your husband about once a week in plain, simple man language. Don't be subtle, don't be indirect. Just say, Bob, I'm not leaving and I'm not seeing anybody. The guys get weird during the first year. They see all this energy. Everybody's telling you how good you look, and he's wondering, what is this beauty going to do with a mutt like me? And they start to fantasize that you have to leave, and then they start to fantasize that you're already with somebody, and then it gets awful. And I see it happen so often, I warn everybody, don't let this happen, you know? I mean, the good couples, they start to have fun again, you know, start to play again, start to do things. Next thing you know, they got rollerblades in a canoe, you know, and they're starting to, you know, get their exercise together, to start to do activities together, and that's a good thing, I think. All right? So a lot of things going on. It's a multifactorial thing, a lot of things going on, and, you know, if it was simple and easy, there'd be an easy solution, and it's not. It's not simple, it's not easy, and it's complicated. All right, but I'm going to try to share with you the things I've learned over the past 14 years of doing this to try to help you get through this well. All right, so we do 3 operations here. We do gastric bypass surgery. We do an operation called adjustable gastric banding, or used to be called lap band, and then somebody patented that word. And we do an operation called a sleeve gastrectomy. And which one you pick is kind of up to you. Everybody kind of has a preconceived idea of what they want because they know somebody that had it and did good, or they know somebody that had it and didn't do so good. But, you know, try to keep an open mind to learn about all 3 of them so that you can make an informed consent for yourself.